So my primary interest is skin cancer, and skin cancer is a very broad summary of various diseases, including malignant melanoma, Merkel cell carcinoma, lymphomas of the skin, and non-melanoma skin cancers, epithelial types of cancers deriving from skin, which are actually the most frequent cancer which humans develop because of sun and immune suppression. So my prime interest is malignant melanoma. Melanoma is the skin cancer which is responsible for 80% of deaths related to skin cancer. So it's a deadly disease which is diagnosed early. Actually, the median age is around 50, but with a very wide span between the 20s to 80 years of age. And if it's detected early, it's clear you can cut it out, you can cure it that way, and in the Western European countries this is the common standard. So early detected melanoma has a cure rate way above 90%, 95%. However, as soon as we have spread of the disease, prognosis drops. So the first usual spread is into the lymph nodes, so regional disease. You are actually looking for that by a procedure which is called sentinel node biopsy, which is a minimal invasive surgical procedure capturing this first draining lymph node. And then if this is not enough, then also melanoma cells might spread into visceral organs, distant organs, including lung, liver, brain. And obviously this is a deadly threat for the patients. And for decades, as soon as a patient had been diagnosed with advanced metastatic melanoma, this was more or less a death penalty, because patients had to die within 6 to 9 months. That was the median overall survival time for those patients. And this has changed over the last 5 years. And what I have been summarizing in my talk here in Portugal was actually the evolving landscape treatment options for patients with advanced melanoma. This meeting is actually important to educate the next generation of cancer researchers who have different angles on cancer and the disease, starting from epidemiology, combining it with the newest techniques in epidemiology, statistics, profiling omics technologies, but also keeping a translational clinical focus on what is the disease, what are the problems, what is the most urgent medical need. And if you are a physician, an MD, looking at your problem, you definitely need help using all these new sophisticated techniques and possibilities, platform technologies. On the other hand, if you're a trained PhD, you have possibly all this knowledge in a subset of these new developments. But the question is how to apply and bring together in order to improve diagnosis, prognosis, and at the end, outcome of patients suffering from cancer. I think malignant melanoma is a perfect example that after 30 years of experimental treatment using also chemotherapy, we have not made any progress. So patients were still dying within a year. Chemotherapy had no effect. I think what was done at that point is to establish study groups who work together, which is already key thing, working together. Now we have learned that, for example, chemotherapy is in most of the cases not necessary anymore because we have much more efficacious treatment modalities based on basic discoveries. One example is targeted therapy for malignant melanoma, based on a breakthrough paper published 2002 in Nature, discovering BRAF mutations in numerous tumors, including melanoma, which had the highest frequency. Selective BRAF inhibitors were developed, and they have been approved within 10 years after description of this basic discovery in Nature, and have shown that survival is improved, dramatically improved. And now we have actually even more drugs targeting this MAP kinase pathway, for example, combination of BRAF inhibitors and MEK inhibitors, leading to an even further increase in overall survival of these patients. And I mentioned in the beginning, the median overall survival time was in the range between 6 to 9 months. And now we have median overall survival times well above 2 years, and there are even subgroups who have median overall survival times more than 4 years. So we are approaching a significant subset of patients having a survival chance of roughly 50% at 5 years with all the new drugs available. So that's one perfect example. And the second perfect example in melanoma is a better understanding of the immune system. So, I mean, we have been busy analyzing the immune system and actually also studying the interaction between tumor cells and the immune system quite intensively in the field of melanoma. Based on these research, the first tumor-associated antigens were discovered and described as MAGE antigens recognized by T cells. And based on that, various vaccination strategies were developed, and all not successful because we didn't understand how the immune system is really working. We had only a very small subset of patients who had shown a benefit in regard to this experimental treatment modalities. And now we know that the checkpoint control between immune cells are of critical importance for controlling tumor, affecting the tumor, but also keeping autoimmunity in check. And using now checkpoint inhibitors, checkpoint activators for the first time have shown that there is a really dramatic impact on melanoma patients, even in an advanced stage. And 3 antibodies targeting checkpoint molecules, ipilimumab targeting CTLA-4, and the PD-1 blocking antibodies, pembrolizumab and nivolumab, have already been approved within the last 3 years because they have shown dramatic increase in overall survival. And possibly we have for ipilimumab already long-term survival data. We are seeing that roughly 20% of these patients seem to be having a long-term benefit, surviving 5, 7, 10 years without relapse of the disease. And I think this is very fascinating. So I think the take-home message is pretty clear. I think we have made some progress for our patients, looking from the clinical perspective. On the other hand, we have we have generated so many more questions. I mean, obviously we are not curing all patients. Whether we are curing patients is still open because the development is so young, but I mean, not all patients are benefiting. So we have questions on targeted therapy as well as on immune oncology approaches, on primary resistance. Why don't patients respond in the first place? Then the question of acquired resistance. So patients have a certain response, have a certain tumor control over a year, 2 years, or even longer, and then tumor is relapsing. What are the mechanisms? We are seeing that there is an interaction of the immune system and the tumor and the microenvironment and the critical part of the microenvironment. So there is inflammation, the role of inflammation. Can we use that also for better understanding patients who are benefiting, who have a better prognosis? So we need to understand if a patient sits in front of us, what is the best treatment modality now? How can we select the best treatment option right from the start and not do try and error and see if it works and then move to the next one? We need diagnostic research in terms of monitoring minimal residual disease in order to follow the disease, also to see as early as possible relapsing disease, and to study these minimal residual disease more carefully. So we need all these technologies, and we have so many questions to ask to be implemented in our daily algorithms, how we would treat and follow cancer patients.